Okay. And again, Charlie, this will be available to the people who have access to my website, right? So it won't be something that goes everywhere, all over the place and crazy. Although you probably wouldn't mind knowing you. So let us begin today. Welcome, everybody. Thank you for joining today. It's Sunday, October 19th. Um, there are a few admin items that I want to throw out there first. Again, this is being recorded, uh, and you have the freedom to have your video shown here or not. Everybody will be on mute except our guest and myself. Uh, this will be an interview with one of the icons in the professional community on the OCD recovery side. But everybody needs to keep in mind that this is not intended as therapy for you as you're being seen. This is for information to give you insight. If you are in crisis, remember that you can always reach out to 988, the suicide uh, crisis line. If it's truly an emergency, you can dial 911. And so I just encourage everybody the chat room is open, be respectful of others. Let's have decorum. At the end of the interview, you'll be able to ask Dr. Mansueto questions. If you have a question, just go ahead and hit the raise your hand sign, and I will see you and I will call on you. Uh, with that, let's go ahead and get started. Let me introduce our guest, Dr. Charles Mansueto, or commonly known as Charlie, is founder and director of the Behavior Therapy Center of Greater Washington. He received his doctorate from Catholic University and completed his postdoctoral clinical training at Temple University School of Medicine. He has over 35 years of experience in the application of behavioral therapy to a broad range of clinical problems. Dr. Mansueto has written extensively and presented uh, nationally and internationally on OCD and related disorders. He currently serves as a member of the Scientific and Clinical Advisory Board of the International Obsessive Compulsive Disorder Foundation, IOCDF, and chair of OCD Mid-Atlantic, an IOCDF affiliate. He also serves as the scientific advisory board or serves on the scientific advisory board of the TLC Foundation for Body Focused Repetitive Behaviors and served on the medical advisory board of the Tourette Syndrome Association of Greater Washington. He retired as a tenured professor of psychology after 35 years in the University of Maryland system. So please join me in welcoming Dr. Charles Mansueto. Sir, it is absolutely a pleasure to have you here today.
Thank you so much, Shannon. I'm happy to be here.
Okay, so a quick story. Dr. Mansueto is the very first physical being outside of my own two Navy doctors who treated me at Camp Lejeune, North Carolina. And then as I moved on with a couple of other therapists inside the Navy Marine Corps system. But Dr. Mansueto is the actual first physical person I met after the International OCD Foundation asked me to be the keynote speaker at the 2010 annual IOCDF conference. And what happened was, I'll share my screen and I'll show you the picture, but the Washingtonian magazine contacted me and contacted Dr. Mansueto and asked if the magazine could interview us as a precursor to the International OCD Foundation conference. And I said, sure. I really didn't know anything about this space, but I said, yes, nervous as all get out. And then met Dr. Mansueto at a location, and it was prior to me giving the keynote. And I can only say that your graciousness and your calm demeanor really calmed me down. because this was my first entry point, and you were such a gentleman. But real quick, I want to share this picture so everybody. Oh, come on, it's not working. It's not working. My- Hi, do we have everybody? Okay, we're back. Can you hear me?
Yes.
I don't know what happened. I went to share my screen and my computer decided to not cooperate. So what we will do here is, okay. All right, we're good. I'm not going to share that because I don't want to screw anything up now. But anyway, there's a picture that exists in the Washingtonian magazine of Dr. Mansueto and I sitting. I'm in a chair, he's on a couch or the other way around. And it was a really nice interview. It went for several pages, but I'll post the picture later. Uh, so with that, it truly is my honor. I consider you to be like, if we had a pyramid of all the greats, um, in this community, this space. You and I go back a long way, starting with that interview, but also Dr. Mansueto and I worked together to get the OCD Mid Atlantic affiliate up and running. You had already started it and wasn't where you wanted it to be. And so you corralled me and Carter Waddell and said, hey, let's get this thing going. So we worked really hard. And shortly after that leadership that you showed, I think there was like an explosion of board members that came on, all the young whippersnapper therapists in the community. They said, we want to get involved, and it took off, and it's thriving better than ever still today.
Yes.
So anyway, uh, I'll pause there. I just want to welcome you, and then after you say hello and whatever you want to say, I will I have a list of questions that I want to ask, and then we'll get through there, and then we'll open it up for Q&A. So thank you for coming, Charlie. I really appreciate it.
Thank you for inviting me, Shannon. I'm happy to be here.
Okay. So um, I hate to start out clinically, but that's the way we're going to start out. Because just for the audience, um, just kind of in a 101 type, you're a college professor, but in a 101, what is OCD? Is it new to the DSM-5? You've been doing this for a long time, but could you give us a little thumbnail about what OCD is?
Yeah. Um, OCD has been recognized as a problem probably since people thought and felt. It's a one sort of trap or problem that many human beings can fall into, and for some it becomes too pervasive, too severe, and begins to interfere with their productivity. So I could give you the kind of orthodox view of OCD as a disorder, a neuropsychiatric disorder that is characterized by obsessional material on one side of the board that is exaggerated or even irrational fears of unlikely outcomes, and on the other side, the compulsions, the things that people do to try to keep them safe and make them feel better about these threats that they believe are looming out there for them. And that's the orthodox view, a disorder, a medical, psychiatric, psychological disorder. But I think there's another way to look at it because it's been around before disorders were characterized. And so I think that this is just one of the many traps that can bother a person in the course of their lifetime. It can be at a non-existent, I suppose, but at a minor point. Doesn't everybody have some areas that they're more preoccupied about with than others? And doesn't everybody have some compulsions, things they are really unnecessary, but that they feel that they repeat as patterns because it makes them feel comfortable, feel focused, and feel more together. So we can look at it as a sort of a heavy disorder, psychiatric, or we can look at it as a common human trap, and that's the way I prefer to view OCD. Mhm.
What what drew you initially? Again, you've been doing this a long time, and that's not a comment about your age, but what drew you initially into being interested in treating this disorder, and kind of how has your, if it has, how has your perspective sort of evolved in
Yeah.
this space?
Well, I sort of fell in love with psychology back at Rutgers University in the dark ages, and I had a bunch of wonderful professors. My abnormal psychology professor was particularly stimulating to me, and I was following it and thinking about a career in clinical psychology, but didn't really feel I was ready for that, even to commit to that. But toward the end of the semester, he was reviewing some of the things that he had taught us, and he said, "Now everybody in my class right here understands the difference between, and these are old terms, neurosis and psychosis, right? Neurosis being problems of living that are more not as severe. We that people follow the same rules as everybody else. They don't have something taking them into a world of fantasy and but they so that was it. And everybody said, yeah. And the psychosis, of course, a little bit on the different side. You're a different person. Different things operate. It's hard to talk with you. It's hard to understand you because you are thinking in crazy ways, and so therefore you're in a sense the other. But he said, everybody here, if you had to have something, right, you wanted psychosis or neurosis? Everybody said neurosis, right? He said, but wait, he said, we have here at Rutgers, we have groundskeepers and food service personnel and many students who are psychotic. They're taking medications, though, that manage that, and they're able to have quite productive lives. He said, but there's a neurosis called OCD that we don't have any cure for. We don't have any treatment for really. There's no medication known to science that makes an impact on OCD. And even Freud, in his discussion of obsessional neurosis, felt that psychoanalysis was not appropriate for that. Well, that got my ear, it bugs me that there's something that's different and no one knows why, right? And that stuck with me. Although I went into the area of experimental psychology first, I felt that was my calling. Way back, there was a movie called David and Lisa, and I was just so struck by this movie. It's obscure. It's a kind of 60s, more experimental kind of movie, black and white. Uh, but boy, did it hit me emotionally and physically that I wanted to now shift my attention from experimental psych to helping people. Uh, One of the individuals, David, had a form of OCD. And I sort of watched this movie over and over to learn more about the young girl, Lisa, who was psychotic, and David, who had OCD, a very severe form, how they connected and became, and it was human qualities that led each of them. They had very good care. Took place at Chestnut Lodge in Washington, right near where I practice. Anyway, it affected me so much that I switched at the last minute. From I was in a master's program. I switched at the last minute to apply for clinical psych positions, and that was the beginning. And I've never lost my fascination about OCD. I love the people that I meet. I love the fact that it's challenging, that I learn from everybody that we meet, because everybody is different. Everybody has a creative mind and created their own ideas about what they are focused on for reasons that actually I'm doing some research now with some Harvard folks, really some writing about the potential mechanisms why people take the form of why in their OCD with scrupulosity or body dysmorphic disorder or contamination issues or checking with others to make sure that they haven't done harm to them or to anybody else. So anyway, and I also came to realize that in psychology there were so many holes, so many murky areas to investigate that you didn't have to be Stephen Hawking. You didn't have to be a giant or even a Freud to make a contribution. So that's where my research interests, my clinical interests have traveled to the dark corners of OCD. You probably know, you do know, Shannon, that skin picking and hair pulling was even less understood as what it was and not believed to be widespread. And that's an area that I focused on and thought it needed some illumination and further development of tactics to help individuals with that. So I came up with the idea of COMB treatment, comprehensive behavioral treatment, which is now widely used, and I do a lot of training in that area. Another area that people don't that I felt needed something was the interaction between Tourette's and tics and OCD. It had originally been in two parts of the diagnostic manual, two different chapters. And in my early work, where I emphasized work with children, I was in charge of a child and family program at Temple. Edna Foa, you know who she is. Many people
Yeah.
know her. Almost the goddess opening up the doors of OCD. Amazing. She's one of my supervisors when I was a postdoc. Well, I got invited to stay on as a faculty member, create a child and family program. What I had then were many kids who came in with OCD because Edna made Temple Medical School sort of the one center, one of the major centers for treatment and experimentation. And so I had lots of people, and the kids who came in often had tics. And not only that, I saw a relationship that one kid sent by their doctor for tics, another complex tics, another kid sent for OCD. And boy, they answered the questions the same ways. So I said, there's more of a connection here. And that's why I introduced the term Tourettic OCD into the literature in 2006, and it continues to grow as a respected conceptualization of a kind of emerged form of OCD and Tourette's that is neither fish nor fowl and requires modifications. And some research done at Harvard supported it with 15 years. My original article on Tourettic OCD was based on just purely clinical observation, an argument, and a rational theory presented. But in 2022, some folks up at Boston Children's component of Harvard's found that the research over the last 15 years up to that point, 2022, supported many of the clinically based assertions. And so it is now grounded empirically, and there
Hmm.
is more research and thinking and training incorporating Tourettic OCD into the mix. So that's what I love about psychology. I love about OCD. OCD is so rich. I get to meet incredibly fascinating, brilliant people with who are creative and funny and very conventional in the sense that they're kind of people you kind of wouldn't mind knowing in your life as well. So I've had that opportunity. I have scores, hundreds probably of individuals that I've worked through the OCD component that made my life better, just knowing them and learning from them. That's
Yeah, I mean, a couple of things. One, our lives are, I've just experienced this doing peer support. My life is so enriched in meeting everybody that I've met, both people who suffer, the therapist. And one of the things that really makes me uh, fills my heart with joy is, like, for example, at the IOCDF conference, just watching everybody, and we'll just go with the researchers and therapist side. Everybody is so curious about how to move the ball forward, right? You can see it in all of the research displays that are out there, but just talking in any of the sessions that are there, hearing people talk, everybody's so curious and just has it within their heart. They want to move the ball forward in research and treatment and everything else. And you, just personally, I know you and know what you've done. You are responsible for training so many therapist, right? Bringing them up and leading them through. And I'll get back a little bit later in the interview to that. But in your own journey, can you think of one or two personal stories? It could be from someone who suffered from OCD, but it could also be from a young therapist. Anything that has possibly helped you in your understanding of OCD, right? Anything that comes to mind.
Well, there's so many things. I mean, I've been shaped by the people I've encountered, both professionals and through my clinical practice, and the training I do. I have been involved in lots of training over the years of other therapists, young therapists. I'm very interested. I'm really a professor at heart, not a doctor, really a professor at heart. And I like to teach. I think of therapy as teaching and coaching rather than doctoring. I don't fix anybody. All I can do is tell people things I think, as your professors might have and your teachers, tell people things that I think they might want to know because they can use that to better their own lives, to be more creative, to be more fulfilled. So that's the way I think about therapy. I'm there is to teach, to coach people using the things if they want, the techniques and approaches that I've mentioned, and then the greatest day, although it's always bittersweet, is to say goodbye and say, I don't think you need me or any doctoring anymore, that you're on your own and you now know how to live your life in such a way that life itself becomes a doctor, a therapy, a clinical experience. So if you make the right choices in life, if you know what the right choices are, and you know what the mistakes are, the things that deepen that OCD hole or any other clinical problem, if you know that, then it's your choice. And that's where the coach says, give me some more. You can do more. I think you can go further with this. Come on, Rocky, give me 10 more. That's what I think the other part is. And when I see people who grasp on that, and especially, well, I would say because my work with younger people, feeling that we can do something when they're young, before it's become an adult pattern. Then I think we can, with certain forms of OCD, we might even prevent OCD, which is interesting to me. And that's some work I'm doing with the folks at Harvard to talk about a perspective on the maturation process and the development of the nervous system that might allow us to understand better what can we do at earlier points of OCD development, and that might in fact forestall, prevent a lifelong suffering, you know? Not that it can't, adult OCD can't be handled, it can, but there's something about learning and the fact of practicing patterns of behavior over many decades or even over a number of years that locks them in a little more. I mean, if you've done the same things the same way,
Yeah.
breaking habits isn't easy. And that learning process is the basis really of CBT. And that's what CBT is. Apart from the medical perspective, it's another perspective that uses known learning principles based on research that's been done over a century, from giants in the field like Pavlov, Skinner, Ellis, Bandura, Beck, and combining and seeing that each person has contributed some component that enables us to know that there's backing our work are principles like aerodynamic. If you build a plane that doesn't follow aerodynamic principles, it's not going to go off the ground, right? Or so same, we know that there are principles underlying it, and because we know there are principles that underlying behavior, feelings, affect, and thinking, we know that they operate in a predictable way, that we can apply those principles and
Mm.
in clinical form. And that's what we do. That's my perspective on the nature of what we do. So it was the kids, I think, who made me understand better working with them early that OCD takes many, many different forms. It's a product of the creativity of every individual. And because it's created by an individual, there are aspects of it that I can learn from. There are new twists, new angles on it. And once that's understood, then there might be modifications or additions to the treatment that can bring a person further than if we just follow the cookbook, of how to do it.
Yeah, well, and this might be a segue or the beginning of your answer to the next question, and that is, with all your experience, what do you think is probably not doesn't have to be just one thing, but what is most misunderstood about OCD?
Wow. I mean, it depends on who is the person we're talking about with the misunderstanding. I mean, OCD is earlier when I was in college, it was considered a very low probability disorder character, and people needed to be institutionalized because they try every kind of drug and nothing seemed to work very well. So people were not handled at all well by professionals. So there had to be research to begin to clarify what do we need to get rid of and what do we need to keep in our professional understanding. And of course, that's a scientific aspect, and it takes a while. We're still learning about gravity and, gravity waves and things and it's very different over this now different models of understanding that Newton versus Einstein or something would tell us that shifting ideas have implications for our understanding of things. And then we can use those new principles, new discoveries. So there's so many different areas that were misunderstood, that were characterized. Even now, OCD, maybe the pendulum swung a little bit too far because it's kind of funny, oh, that's so OCD, and oh yeah, I have a little OCD, and I think that playing it as sometimes we think of it as too or it's portrayed. I like the fact that people know the term and they understand basically that there are human beings who have these patterns, but sometimes it can be trivialized and not always portrayed well. And those are things that so I could, we'd have to spend another 2 days, Shannon, for all of the
Okay,
things that
okay, we
we
will.
understand.
So,
So
um,
my lots more to learn, but we've learned so much that there's probably no one thing that's going to change, one misunderstanding that needs to be corrected that'll change the field.
fair point. And when you mentioned the trivializing of OCD, I think everybody who suffers from OCD, and certainly like people like you who treat people who have OCD, it really is hurtful to hear people trivialize it, because if you don't have it or you haven't treated someone who has it and you're like, or you're a family member who sees it every day, you don't know how much pain it truly comes with these things. Um, how, so in that spirit, if you were like talking to somebody who didn't have OCD and you're just trying to explain it to them, and you say, how would you distinguish between intrusive thoughts and the pain that comes with when you have OCD and just normal human thoughts that come in, and I know people who don't have OCD who've had really disturbing thoughts, but they're able to just, like
Yeah,
pop it off. So how would you explain that difference between OCD thoughts and just ordinary human thinking?
yeah. Well, I guess descriptively, one might say that, well, think of it this way. We all have concerns, and we know of threats to us. We know threats about crime in the streets or accidents on the Beltway or terrorism, nuclear threats, environmental threats. I'm here in a shore town that has in the past been parts of it wiped away by floods, and we know now. So I'm wondering how long before I have beachfront property here, because of the ocean encroaching. So, of all of these things that we worry about, with OCD, it seems that one stands out. One has mushroomed up and far above the landscape, one or two, a handful really. Rarely do people have, I call them themes, other people call them themes or obsessional, content. And it might be about God. I mean, that's a powerful thought that there is a being that watching us, caring about us, and also to some ready to punish us if we haven't done well, or at least not reward us. That's a scary thought. Now, same thing, someone worrying about a disease. Well, for a long time, uh, AIDS was on the landscape, and so we had so many folks who were afraid to touch anything and handle anything because they thought on every doorknob somebody might have touched it that bled, and if they had a little paper cut or some way that they might get it. So somehow something caught the imagination of people who are vulnerable. Vulnerable, why? Maybe constitutionally, not all of us are prone to addiction, for example, some more than others. So we have different characteristics. We have different vulnerabilities. We all have things to work on. Well, in OCD, it becomes very clear that there are just a few things that overly are entertained by that individual. Their mind can't stop thinking about it. There are too many cues that provoke it, internal and external. And then I think a trap, that's the potential. The trap gets sprung when a person begins not to use good problem solving, but to use compulsivity. Now, compulsivity often is the only thing that is washing after touching something or asking for reassurance. I didn't hurt you. I didn't say anything awful, did I just then? Or going back to make sure that I didn't hit a body with my car into the woods or leave people in the street. So that feels so immediately rewarding to, wow, I got the reassurance. I feel clean enough now. The immediate reward is in psychological terms negative reinforcement. Usually people think of that as punishment. It's not. It's when something unpleasant has been removed. That's a very reinforcing event. When you put your coat on because you're cold, that's reinforcing. When you put sunglasses on because the sun's in your eyes, that's reinforcing. And you'll tend to remember that next time to bring your glasses. Make sure you're dressed warm enough, right? So now people are relying on the one thing they've hit on that seems to provide them at least a temporary or a modicum of relief. Other things, working your way out of that pit of concern and foregoing the rituals are hard to do. It's like telling someone, clinging to a tube in the water that they can swim well enough and just let go of the tube. That's easier said than done. But in a moment of extreme anxiety and fear, people will latch onto that tube. They'll latch onto someone who's trying to save them in the water and pull them under. So often there is a pattern of unwarranted, unadaptive behavior that's been so firmly established because it follows ordinary human principles and principles of learning that it now takes them into the deep end we call OCD. One of the number of what I think are human traps that can catch people with certain character. You can't have true OCD, traditional OCD without a free-ranging mind. Right? Who doesn't like folks with a free? You like a friend who can think of different things, being funny, offbeat, think out of the box, being very creative. Bosses like industrious people who can come up with new ideas. So that seems to me, is one of the critical components of traditional OCD. On the other side is it doesn't happen to cold fish. In fact, for OCD to take hold, those thoughts and ideas have to jar the person deeply and emotionally for reasons, again, probably unique to that individual's life, why they struggle with that. We can understand if they're brought up in a religious community that's very fearful and feeling very much a need to follow rules to the letter, and you can't always know when you've done it well enough. It's a whole lot like rituals. They're almost like religious practices. You feel better if you've communicated well with God, if you've gotten a sacrament, or if you've gotten followed a certain procedure for the church and for the synagogue that enables you to feel better about it. Well, it's not that different. So you take the critical mind, the free-ranging mind, no shut-off switch, right? Always going, and then you have a feeling system that is stimulated by the mental process alone. And everybody isn't like that. Everybody can imagine fearful things and feel equally upset by it. I've worked with 10 elevator phobics once. And in the old days, we used something called systematic desensitization, which we had people imagine things like looking at an elevator, walking toward it, stepping on it. I had 10 people in one room, and I had them very deeply relaxed. And I said, now think of the elevator, the last elevator you encountered. Can you picture it? Well, already people's hands are going up. And then I said, now imagine yourself walking toward the elevator, watching people go on it, uh, and maybe even, you stepping on it and stepping. Well, so only about half of them actually reported anxiety, which was not good for systematic desensitization, meaning they weren't accessing those emotional channels through their symbolic systems. So that enables individuals with OCD who have these powerful abilities to be very empathic, to be very novel. The kids who would come in with OCD, and they'd be funny. They'd be ripping on me and drawing pictures of me, and it was a riot. I loved them in my clinical day because it was novel, stimulating to me, enjoying the way their minds worked. So too much of an emphasis on the negative side uh, may, for any of us, uh, begin to cloud out the fact that there are many positives by individuals who are said to have OCD, and that we can build on those positives in unique ways when we know what their individual ideas and fears are, and know how to work with that, but also to understand the strengths and abilities that we can build on or that we have to bolster. Because you take away OCD, sometimes a 20-year-old who's never completed their education, who has had great potential for a 30-year-old to have gone to college and followed, and now to dated, to have relationships. It isn't enough to remove the OCD. Sometimes we have to help build the alternatives to create a rich life that in some way replaces some of the mechanisms that have been practiced for so many years or even decades.
Yeah, and I think you're starting to bleed into this next question. So you're a master at this. You mentioned earlier cognitive behavioral therapy, right? And I know that when I was diagnosed in 1997, the late Dr. Michael Janicki, you might have even said this to me, said I was very fortunate that those two young Navy doctors nailed my diagnosis when they did. But I might be misremembering this, but I've always remembered them saying that they were going to put me through behavioral therapy. Didn't call it
See,
cognitive behavioral therapy, but it was behavioral therapy. But basically, what I know about cognitive behavioral therapy, that's what it was. And the concepts that we talked about, principles. So for the audience here, could you give us another 101 on what cognitive behavioral therapy is? And then also, you know, if what is ERP, exposure and response prevention therapy? Is it the same as cognitive behavioral therapy? Is it a form of cognitive behavioral therapy? Is it something different? But if you could sum all of that up
yeah,
for us.
that's a because historically things have changed quite dramatically in no time at all. There wasn't even a name for this when I was in college, and it just was called behavior modification, right? Then, as it began to broaden and be more applied to clinical issues, not just getting kids to stay in their seat or getting kids to stay in their room at night, that was behavior modification using Skinnerian principles and other ones. When it began to be broadened to take into other accounts, to understand that we were working not only with behavior, but with the three-dimensional nature of human existence, uh, when when I formed my clinic, we called it the Behavior Therapy Center of Greater Washington because not before the 1990s, behavior therapy was the name that replaced behavior modification. And they kicked around was behavioral psychotherapy and other. Nobody knew exactly what to call it. And so people were doing things and not even recognizing that they were in the same world. So it began to so behavior therapy in the 90s re reacted to what was called the cognitive revolution in psychology. The idea that psychology had lost by rejecting Freudian type notions about the mind and the unconscious and focusing on the id, the ego, superego, things you couldn't really find on a brain scan. It was just a purely conjectural, metaphorical way of looking at it. So eventually, there was a renewed interest in the thinking and mind, the way the mind works, and how it functioned in OCD, among other things. It was so influential in a sense that Beck and Ellis in New York City, Beck in Philadelphia, most people know Aaron Beck's cognitive therapy. This field had to make a decision. Is it going to be split into the cognitivists and the behavior therapists? But there were major meetings, and there was a decision to and it was mainly, I think, in part, it was in Association for the Advancement of Behavior Therapy. Do you know what that's called now? Association for Behavioral and Cognitive Therapies. So all these two warring sides, doesn't it sound familiar? Us against them decided we're more alike than different. And from that point on, it was called cognitive behavior therapy. So if I were naming my clinic now, I would call it the CBT Clinic of Greater Washington, not the Behavior Therapy Center of Greater Washington. So that's about that. Now, what is CBT? Think of it as a very large umbrella that captures many approaches, clinical approaches that do believe that human behavior follows rules, that it's not haphazard, that things don't appear out of nowhere, that like physics, we understand that the movement of the moon and the stars and all of that followed rules, but we didn't know what those rules were as human beings for centuries, so it seemed chaotic and mysterious. But once more research and study went into those things, we finally understood, this makes sense. Earth is not the center of the universe. This is in fact, in the remote corner of a small galaxy at the edge of the universe. And that's what CBT is. It's the universe of common thinking people who believe that there's a scientific uh, way of learning how best to do clinical work to address the problems that people present. Most of it is carefully geared to existing theory. But because it's a new science, we also have to recognize that approaches that seem to have, so people report this works, that works, do this, do that. And Shannon, maybe others know that there are competing views, like, for example, the view of habituation underlying CBT versus change in cognitive beliefs, the other approaches, that would argue that all it is learning that I can do things even when I'm uncomfortable. Now, there's work that has to be done to decide what do we reject and what do we keep. So some will grab on a lot of new things. DBT, wonderful, but it is not new in many ways, except combining it to talk about a systematic, methodical way of working with uh, people who are in very difficulty managing emotions and dealing with other people. Um, ACT, 3,000-year-old principle, Buddhist Eastern philosophical principles. They work. There are many things about acceptance and meditation that really work. So the necessity is to not be willing to grow and to learn how we can pull more things under the umbrella and reject others as cultist or non-scientific or not really following any no. And so we have now from the OCD community, just published from the OCD Foundation, guidelines, first tier recommendations, second tier recommendations. If first doesn't work, you might add this to bolster it. Third tier, maybe some experimental techniques that might be tried when other things don't work. But don't grab on the diets and anything other that in the hopes of a shortcut without exploring the ones have been shown over the past 30 or 40 years to be highly effective for what before was an untreatable, remember my Rutgers days, an untreatable disorder, mysterious in that people seem to be healthy enough to function better, but there was something keeping them down. And that was what we were able to unravel and still unraveling more. So I don't know how to confuse the issue. It's a complicated thing, but that's the way I look at it. That like any
Oh,
science,
that's helpful.
continues to grow, and we derive from it practical things to use. Transistors were practical applications of many of the principles that were found to underlie, the electromagnetic aspects of things. So same here. We're not that different.
So is ERP, exposure and response prevention therapy, a form of CBT? Is that
It is. That's what I,
okay?
I didn't clarify. That ACT, DBT, cognitive work, exposure response prevention, reward systems, exposure as a tactic without response prevention. All of these things can be seen as related and within the domain of scientific they can be studied scientifically and determine what is useful and what isn't useful. And so what stands that test tends to be pulled under the umbrella. So there are many, many, many different techniques. We don't know, I don't know all the techniques that are called that are under that umbrella. I use the ones that seem most appropriate for my clients and the ones that are most comfortable for me to use. Like a lot of cognitive techniques, I would tell people to use mainly, it hurts my head to follow my thoughts and decide which one is adaptive, which is unadaptive. What do you call this? A mind reading or jumping to conclusions? Then I have to think what's a more appropriate response to think. Yeah, I'm not really a loser. I'm not born under a lucky star. I didn't do well with that, but I can maybe do well later. Then I have to practice that until it bumps out the old way of thinking. Oh gosh, my gosh, I don't have any room in my day. So we look for simpler, effective ways that stand that scrutiny, scientific scrutiny, to work, and we kind of push the other ones a little bit aside as we learn those things. So CBT is a just a broad general approach that in which what is in common, I think, with people is who follow that is that we believe that human behavior is understandable, it's predictable, that it's changeable, but changeable when we are applying the right principles to change that behavior and that thinking and that feeling that the people have. And CBT is an example of that. Pavlov, those of you who remember the drooling dogs from your, here or there, Pavlov was learning how involuntary responses, right? When we salivate, we don't think about it. Our mouth is working pretty well, and when we eat something, it creates more saliva, and we don't think about it all day. If we think about it, we interfere with it. That's another form of OCD, sensory motor OCD, where we focus too much on one process, like breathing or where our toes are in our shoes, and it becomes so distracting because we're trying to get things just right. And that's so hard to do that it takes more and more focus, concentration, and distraction. And then their life can be drastically changed. So see, exposure response prevention uses, in a sense, Pavlovian principles. One way of looking at it. Pavlov said, if you condition a dog by pairing food powder and a bell, and you'll start salivating to the bell alone, that's classical conditioning. But what if you want to get rid of that response? How do you get rid of the response? Well, he said there are two ways. One way is to continue to ring the bell with no food. That's extinction. That's what we think of as habituation. Or we can we can introduce something that produces an antagonistic response, like an electric shock. You shock a dog when you ring the bell, and suddenly they'll stop salivating. So those principles, into clinical terms, can be used to understand habituation, why we give people things that upset them. They're saying, why are you making me feel uncomfortable, doc? It's like ringing the bell. Because we think if we can help you experience that discomfort without resorting to anything that cuts it short, then we're not giving the dog food after a minute. We have to let that dog not experience food and for the bell to the response to habituate. And that's the same thing in CBT. We give the person something over and over and they react less, like someone tells you a joke and you laugh the first time. Second time, third time, oh yeah, I heard that one, right? So what happened with repetition, the emotional response is diminishing. And we can see that in everyday life. So I like people to think about clinical work in OCD and any other CBT procedure as applying the principles that operate in ordinary life. And as doctors, as therapists, we don't always do that. We use fancy language and fancy terms, and people say, "Oh my gosh, CBT, it's I don't, it's weird, and I don't even know why you do it." You've done it, and you've seen it in your own life. You've seen where at first giving a speech in front of the class made you shake and quiver and want to get out of it, or swimming in deep water, or going away from your parents overnight. But that with repetition, those things got easier, and you even learn to enjoy swimming in deep water and riding a two-wheeled bike, although you're afraid you'd crash and hurt yourself after the tricycle seems so safe. So these things are not weird. They're not exclusive to doctors. It's not, we don't stroke our beards if we have a beard and say, "And why do you think that?" And suggesting, "I know more than you. I know nothing about you until you tell me more about you," or I read someone's report of you. So that's what CBT is. Just human principles that have been established for behavior and thinking and feeling that we can apply in predictive ways that follow certain theories that seem to serve as good models to check against as we do our therapy.
So let's kind of move into providing therapy to people
Uh-huh.
who are suffering. And so and I could do this for the rest of my life because I only talk about what I know and what I did,
Yes.
right? Where I was, I suffered greatly. I know how I recovered, what I did to recover, and I know where I am now. So whatever I did worked. And people have told me it's kind of a combination between ERP principles and ACT and everything else, or ACT. When I talk about recovering from OCD, I say at the very core of this, you have to stop performing compulsions, right? However, you get yourself to do that without performing another compulsion to do it, you have to stop. What's so difficult from the sufferer side is, and we all know this, and you know this having treated all patients, what makes it so hard is because it does strike you at the emotional level, and it feels like you're taking actual risk where somebody could get hurt or whatever the consequence that OCD feeds you. It feels like real risk, and the fear is actually real, right? You're feeling actual fear about something that we could look at and say it's not actual risk, but it feels like actual risk that you're facing. And so we tell people stop performing compulsions, and whether they're doing ERP, whether they're however they're doing it. What do you ordinarily tell people to motivate them to get them to take what feels like actual risk, to
Mm-hmm.
not give into the compulsion? Is that a fair question? Do you understand what I'm asking?
Absolutely. In fact, that's a
Okay.
critical question because we, read reports that some people don't respond to traditional exposure response prevention. One third drop out or say they can't do it. Two things happened earlier in my career, and I said I learned from the kids and the young people because I worked more exclusively with them, and I thought that before anybody shaped their thinking about what they were experiencing, before they would learn the terms and why it happened, just listen to them and hear what they would tell me. And two things happened. One was an article that came out in the Washington Sunday edition, whatever magazine, Washington, what? Not the Washingtonian. You put that in my head. Washington Post magazine. One of the young ladies I treated, she was now about 14, 15, but it talked about her experiences in treatment with me, and she had done a beautiful job. It's a wonderful story uh, called uh, who called Removing the Noose. She was very afraid of suicide, and she would have rituals, many rituals. But one of them was she would do this every time she worried that she might hang herself. But meanwhile, she was avoiding graveyard. She was avoiding any mention of she lived in Virginia. There's a place called Coffin's Corner. Any allusion to death. So that's the problem with the inventive mind. You begin to make too many associations, and
Right.
all of a sudden you can think of many ways that this central fear might harm you. That's the good inventive mind going awry, going into the dark corners instead of the creative positive corners. Anyway, that and the second thing, Judith Rappaport asked me, she said, what, the first time she ever saw anybody treated by CBT, I worked with NIMH, and they were doing work on clomipramine, anafenol is the trade name, and they were finding it was the first drug that was useful that actually in a controlled study showed effectiveness for OCD. But it wasn't working for everyone, so she asked me if we would try to treat some of these people who it didn't work for. And one of the guys I worked with very early in that process, a guy named Daniel, she was so, I brought her back to her people, and they, after about 3 months or 4 months, and she brought her folks in, Henrietta Leonard and Sue Sweeto, two giants in the field. She said, we have nothing in our models to explain why Daniel got so well so quickly, right? So now they were alerted to the fact that an entirely different approach, a learning-based approach, might in some way be as effective or equally effective or maybe even more effective for a number of cases than the clomipramine. And and she asked me to write that chapter describing Daniel for a textbook on adolescent OCD, which I did. And now I'm going to come to the punchline in a second, but I will say that she was so taken by that the boy who couldn't stop washing, which is opened up OCD to the world because she wrote that to the general public, and it became number 16 on the bestseller list. So
Mm.
the world was being educated by OCD. She asked me if she might use her chapter, and I said, well, it's such a medical book, and it's such, and I think we're further along, but I said, you can use that chapter, but please change my name and change some of the details so my client feels protected. So I became Dr. Xavier Charles in the preprint edition. And no, I was Charles X. Charles, they take Charles Mansueto, Charles X to get it so they didn't accidentally repeat my name. And then I became Dr. Xavier Charles in the same. Anybody who reads both will see it's the same guy, but there's two different names. The mysterious Dr. Xavier Charles. Anyway, what I learned by reading both of them, the girl that from who was afraid of death and hanging, she said it was the first meeting with me that I talked directly to her. She had never experienced anybody with her parents in the room talking to her. They talked to her parents. And it was
Mm.
like, oh, you poor thing, as if you can't possibly know, inform me. Your parents must. She was very dignified and bright young woman, extraordinarily bright. And so she felt that gave her the green light for the
Oh,
first time to move ahead with therapy and trust. Okay. Now, Daniel, funny about Daniel, we would talk. You can't always do therapy around the clock. We both liked music at the time, and we talked about music. I talked about concerts I went to. He was very taken by the fact that I saw the Doors live. I introduced him to a band I really liked. I loaned him my album. Well, in Daniel, when I interviewed him to write up his case study, similarly, it wasn't the OCD. I thought I did such a wonderful job with exposure response. Maybe I did an okay job, but it was the fact that they trusted me as a guide. They saw something, a person here that could connect. And that's very important. So I began to emphasize more the preparation for the exposure and response prevention to work to help a person, know that I don't know all the answers. I might make mistakes. I'm not infallible. I'm not even, you know, together in every way. I have things to work on too. Every human being does, right? So so let's get in it together and see how well we can do. And so that is something that I was taught that I think is often overlooked because I've been involved in research on OCD and we have a limited number of sessions. They tell you how often, when you have to start exposure response prevention by this second or third session, and there are advantages to that. But I think the establishment of a trusting, caring relationship is the kind of the guiding when we get too scared, if we trust, if we can be talked down, if we can help to understand better why this moment is so perplexing and difficult for me experiencing this, and how I must continue to stay on course to work my way out of it, not to resort to the quick fix. I mean, that's in this sense, that's like a drug addiction, quick fix. I feel great now. I'm not thinking about the fact my life's a wreck and that I have work to do and that I have no more money because I've been buying drugs. Yeah, so now it's how do you get a person back to rebuild the life that they were truly meant for in accordance with their deep down values, right? To live with their values. People didn't ever decide I'm going to be the best washer. I'm going to be continuously asking for reassurance from people in my life. I'm going to, instead of doing is spending my time wisely, I'm going to spend my time worrying about one particular thing or a couple of things that are unlikely to happen. No one wants that. They have fallen into the trap, a common human trap. They've discovered that compulsions, the very thing, Jen, that you're saying, keeps them in that pit and digs it deeper,
Right.
right? Is what needs to be put aside. A person, you don't get a better swimmer if you don't give up the tube. You don't trust driving a two-wheel bike if you don't take the training wheels off. You don't, you know, a kid does not learn to be safe in the world in reasonable places if he needs someone there to tell him it's okay at every step. Sometimes we have to try our wings. And that's really what experiencing the exposure side and refraining or at least limiting our compulsivity, that turns out to be the one gold standard treatment far above any others that's been tried. There's no ray gun, there's no operation, there's no drug. That if there were, I'd go back to treating phobias. I'd love it. But right now, CBT must be a part of at least a good solid effort should be part of it. And by the way, it's a person can learn, get a book and try it for themselves, can find a support system within their friends, within their clergy, within the OCD support groups, the networks. Your work, Shannon, is continues to give people the courage to do that, to get rid of the tube, the training wheels, the parent who's reassuring one constantly to say, I can handle this. And that's when the road out becomes clearer. Not easy,
I,
not even sure, but the way out.
yeah, and I recall, this is not about me, but it dovetails nicely with what you're talking about. What I think clicks in somebody's mind. So the reason I got into peer support was I helped at the request of a psychologist that I know. I helped who was a personal friend of hers. They had tried everything. She suffered from severe contamination OCD. She was starving herself practically to death. They were ready to forcibly admit her. She would not respond to anything. And so her friend, who was a psychologist who knew me through the IOCDF, asked me if I would talk to her. And I said, okay, fine, but who am I? I mean, I'm just some guy. Um, I contacted this woman and we had a few conversations. Fast forward for her, she eats whatever she wants now. She goes wherever she wants. And she credits the work that I did with her, along with her psychologist, with her recovery. But she said, when she tells the story now, she tells it publicly, she said, the one thing that I said to her during our third conversation that caused a light to come on in her head was telling her that she had the power to actually do this. It was already inside her, the power to be able to do this, that she could actually do it. And she said, no one ever told me that. And it was the thing. So fast forward for me, I got into peer support, blah, blah, blah. I got trained, do it. All right, I don't want to run over on time. I know that I've got other questions I could ask you, I would love to do a part two, but I want to be fair to the people who are asking questions in the chat. Let me just go ahead and do those, and if we have some time left, I will ask you a couple of other questions that I have. So let me just go down here. Okay, this one comes from our friend Chris. Um, it says Tourette's OCD and the therapy can be different for Tourette syndrome. If it's not complicated, can you explain an example of that of how you treat Tourette's OCD, and is ERP still incorporated in that? So go ahead.
Great question. Actually, it is, in a sense, it's ERP with some twist in the treatment. Now, for those of you who may not be familiar with Tourette's OCD, the idea is that it grows out of the notion that there's many more commonalities, and it's more and more recognized by the scientific and research community that OCD and tics are related. They're related perhaps genetically. Geneticists say the same substrate of genetics can manifest itself in different ways, some becoming OCD, some becoming pure tics, nervous habits and repeated, sometimes sounds. But what I realized, and I mentioned this before, was that complex tics on the one hand and many compulsions on the other hand, the just right sort of compulsions, are so similar that even professionals would argue, is it a tic or a compulsion? That was the original article. It said tic or compulsion. It's Tourette's OCD, saying that there's a merged form. Now, if there's a merged form that has characteristics of both OCD and Tourette's, then maybe we shouldn't confine ourselves to only the OCD toolkit, even if we think of this person as having OCD, but now a special kind that we look in our Tourette's toolbox, because if it's a merged form, perhaps we can use both sets of principles. Let me give you one simple example, relatively simple. In OCD, we use exposure and response prevention. And you know what that is. Touch the doorknob and don't wash, for example. Go down the street, hit a bump in the street, and don't look in your rearview mirror. Okay, with tics, we don't do that. We don't say don't do your tic. We say do something different. Do something incompatible with your tic in some way. Do something that reduces the likelihood that the tic will occur. Now that means if we have Tourette's OCD, which have a lot of characteristic of tics, perhaps when we do exposure, we should emphasize what the person is doing alternatively, thoughts that they might have, behaviors they might do, other things. Do something different, competitive, that makes it harder to do the tics or more work to do the compulsions. That's one example of the modification. The others have to be geared to the particular manifestation. There's a form of Tourette's OCD that where people get frozen. They have to wait for one gal I just saw who it had to be an even number, the clock said, before she could turn on the microwave. And many other things had to be done to a certain number, an even number, right? It's not so unusual, very OCD-ish, right? But what this person would freeze. And we've had kids who can't come in our office. I see them outside because my window looks down on the parking lot, and I see them frozen, waiting for something to get just right, or trying to get something just right to get through the door. Well, that is important. Freezing is a compulsion for them, which helps them then achieve the just rightness of it. So for a person who are frozen, I found out that, wow, at first I started using a metronome and having them move every time the metronome, whatever it was, move a finger, move an eyeball. And in other words, to break through the frozenness. For people who are really frozen, one kid, actually, the first I did this, I brought him next door to a gym, put him on a treadmill. You can't freeze on a treadmill, right? Think about it. You stop your feet and you're, knocked off the treadmill. So we made it very difficult to do the just right things. So it was sort of just wrong. So things like that when you think of it a bit differently, it's still exposure response prevention. That's still our tools, but we have to look at the experience of the individual and better match the therapy to that individual. And in Tourette OCD, it happens that there are tools for tics that we can incorporate. In same thing with medication. In SSRIs are the go-to drug for OCD, and then it's augmented in different ways, and then it gets experimental if a person isn't responding. Uh, but in also another thing that another medication that's used in Tourette OCD are neuroleptics, antipsychotics at low levels, which I'm not crazy about, especially with younger people. Side effects can be a problem. But there's another group, clonidine, guanfacine, called alpha-2 agonists that are second-tier drugs for tics. Turns out second-tier drugs for ADD when you work with younger people. Often ADD is part of the picture. And it seems to help with a certain subset of the people with Tourette OCD to soften the response. So all I'm saying is that we haven't thrown out the baby with the bathwater. We still have the same principles there, but we're fitting the principles in a more precise, more fine-tuned way, which I think is the trick to broaden our ability to help various, because OCD is many different manifestations, and we give them different. Is misophonia OCD? Is sensory motor things OCD? I think they all have enough OCD-ish functioning that we can use some of those tools, but might have to add other things because of the unique notion of the presentations of those things. Right?
Okay, that's a great answer. The Now I'm going to invite you into the war room. I'd say that with kind of tongue in cheek, but you did mention that there are different viewpoints about within the CBT world about what is right and what's wrong. So this is probably kind of a testy area because I've actually seen some of this debate at an IOCDF conference. So the question comes from the United Kingdom, our good friend Matthew. Dr. Mansueto, what are your thoughts on DBT and ICBT for treatment with OCD?
Yes. Well, I mentioned before that from a scientific standpoint, and I dabble in research, and I always have. I love that part of it. I love the fact that psychology allows me to be both scientific and clinically helpful. That to me and it's so interactive. I mean, the more I learn from the science side, the more it broadens my view of potentials for clinical. And of course, the clinical work informs my notions about scientific things. That's how we came up with new treatments for hair pulling, skin picking, the BFRBs, and looking into Tourette OCD and some other things that cook on the back burners that I'd like to get to. So, so we always have to be open-minded to new things. There's no way that we're at the pinnacle of OCD treatment, right? We're just learning. We're babies still, and there's so much more to learn. So we need to be open-minded and 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 listen to new ideas. That's what allowed me to have comprehensive behavioral treatment be a new form of treatment for OCD that stood the test of time and stands up against scientific research. Tourette OCD, I mentioned that I don't do the research, but the Harvard people have done the 15-year retrospective and decided that the things that I offered on the basis of clinical and rational argument did stand up to empirical evaluation, to the research over those 15 years. And that's where we are with everything new or everything novel that comes into our field. People wonder about EMDR, moving the fingers and having a person imagine what bothers them, and is that a shortcut? I see diets, eat this diet, and you're likely to give up your OCD. We can't believe everything, especially in the age of the internet. So the best thing to do is to look at where do these ideas come from? Do they fit into the existing knowledge and theory base, right? And how might we then incorporate them into our, should we throw out everything we do? No, I don't ever think that. But should we try to incorporate new techniques, new principles that are based on different thinking? And DBT is different thinking. Uh, not incompatible with CBT. I mean, we always worked with people who had difficult with emotions, breathing control, positive imagery, lots of things. It wasn't like we were helpless before Marshall Linehan developed DBT. It's just that she showed methodically that it worked with the most dysregulated individuals. And that told us, all right, then working with it in a systematic way might be something we would incorporate, but not for every person. Everybody with OCD is not emotionally dysregulated, and everybody with OCD is not running out the door when we try exposure. If we're doing the right steps for exposure, gentle at first and giving a person confidence and being with them as they sit with their discomfort, then we can do that and successfully. So there's a long way, I should say, remember, I'm a professor at heart. So ask me one thing and I can go on for a good 90 minutes as a professor we had to do. But so anyway, these things are being evaluated. DBT, when and if it should be used. And you'll see some people, everybody who has OCD has to get DBT first. Okay, is that true? I think not, but let the research show it. If you have two groups, one who gets DBT, one who doesn't, and both then get OCD treatment, are they going to get better having DBT? Maybe some do, and maybe we can better understand when it should be used and when it shouldn't be used.
Okay.
IOCD, ICBT, I just want to say about this, very important. It's being evaluated now. It's seen as a secondary, if the obvious, empirically supported, proven ingredients, exposure response prevention, necessary treatment, if they're not producing satisfactory results, then it's useful to turn to more experimental treatments. Now, I think it's being oversold in a way, maybe, and that happens when something's new. There's new adherents who think it's the greatest thing since sliced bread. So we have to be careful from a scientific standpoint of not grabbing onto anything and then finding out, boy, do we make a big mistake. So now things are more methodical, and we'll find out how ICBT fits in to the range of possibilities. When we should use these techniques for any individual patient, and how successful does that make us be above and beyond what we might have done without it? So open-minded, but skeptical. As Fred Penzel, a buddy of mine in the OCD world, says, be open-minded, but not so open-minded that your brains fall out. Right?
And Dr. Fred Penzel will be another guest on this program. So another one of my heroes. All right, another question. This one comes to us from Austria. Um, and you're starting to tread in with your last answer, starting to tread in this one already. With all the current changes around how we understand OCD recovery and treatment, how do you think OCD will be treated and viewed in the future? What do you think will be the biggest differences, if you have any thoughts about this? And do you think peer support might play a bigger role in the future?
Absolutely, peer support. I think peer support is a critical clinical component, not always necessary, but very desirable. And that's why your work, Shannon. I don't think you should have stopped being surprised that you can help an individual just by connecting on a human level, having understood things well enough to lead them through that forest, that everybody wants a way out. There may not only be one way out, and that's my hopes for OCD. There are more ways out of the forest than one path. But in any case, in the future, here's two possibilities. One, we'll continue to make incremental gains and ideas that come from outside the field or that are incompatible or in some way different from orthodox thinking should be examined and will continue to make us incrementally better at treating OCD. We're just successful enough in 30 years. Well, some things, schizophrenia has been looked at for hundreds of years, So we're just really in the beginning stages. The other possibility, besides incremental benefits that continue to improve treatment, is that there is some major breakthrough. Everybody would wish that we discovered some shortcut. People have tried shortcuts using surgery. People have tried shortcuts using imagery, brain stimulation, brain ablation, burning out certain areas of the brain. Uh, and these some of them haven't panned out so well for individuals because we have to look at the downsides of therapy as well, the potential for risk and danger. Uh, for example, exposure and response prevention came out of a technique called flooding. Flooding was when people said, don't gradually introduce people here, just give them the massive fears, flood them. And it was called flooding. Flood them with fears. And boy, did some people get better more quickly when they were flooded. But some people got worse. And took Edna Foa and some of the research that was being done when I was there, was to examine what was it that made some people get better and some worse. And the idea was that there was not enough prolonged exposure. That if you tell people to tolerate their fear for a short period of time and then say, all right, let's end that now, then the last thing they know is ending it was what helped them, not doing the exposure. So we had to do exposure long enough. And you've alluded to that several times, Shannon, and everybody knows it who has OCD, that it's not easy. It's not easy, and it helps to understand better why it will help me if I have OCD and what my particular form is of OCD. And that not only do I understand it better, I understand it better because my therapist communicated to me in ways that I felt not only enlightened, but more secure, trusting that person to lead me through that forest, past the marshlands, past the bears, past the wildfires, out of there, right? And that's what we look for. So I'd love a breakthrough, and I think it might occur because there's people doing neurological things that I just wonder at. A lot of money is being reported into genetic research. Can we directly change genes and help people with OCD? I'm glad that they're looking in that direction, but I don't want to ignore the incremental work we've done without those dramatic $1 million studies that enabled us to be where we are today, which is much better than 40 years ago, and not as good probably as we'll be in the next 40 years.
That came from our friend Dato in Austria. That's a great answer too. By the way, I try not to change my genes ever. No, I'm kidding. So, um, okay, we're almost out of time. I, one of the things that I focus on a lot is um, the positive approach to recovery, right? Inspirational type approach. Um, for you, and you've done this with so many people. I'm so happy that you were the first, and then Liz jumped in and bumped you. As now you're the second, but that's okay. But it was important for me for you to be here near the beginning of the launch of this program. And as I talked about, if you weren't on before, if we had a pyramid of the icons in this community, um, Charlie would be at the top, right? He would be at my top. He's the first person that I met. Every encounter I've ever had with you since then, and this was back, I met you in 2010. So now we're working on almost 16 years of me knowing you. Every time I've ever seen you, you've been so kind, so generous. Um, and I watch you deal with people, both people who suffer from OCD, young therapists who are trying to make their way. And you're just such like the perfect, if you looked in the dictionary under the word icon, you would see a picture of Charlie, right? So that's how this is. And you've helped so many people. If you could leave us today with, just some kind of inspirational message to people, uh, and maybe to both people, sufferers who don't think that there's any way out of this horrible dark forest, um, and then even to young therapists who, it's different to learn about it and different and than it is to do it, right? So you get in and you're thrown into the fire, and everything doesn't go the way they said it was going to go in school. But what would you say to people who suffer and the young therapists who are in the fire? What would you say to them just to say, hey, keep your head up, you know, finish that sentence. But finish your keep your head up. Go ahead.
Well, first I want to thank you for the kind things you've said about me, but I wish I could be chipped a little lower in the hierarchy because I'm not, I'm not wonderful for everybody. I can't, I wish all of us had a corner on the wisdom, or I did, and I wish I could help everybody in the way they want to be helped, but we're not there yet. And so we have to be humble. However, I've had so much experience, especially early on with the kids, where I saw amazing changes and lives. And I've lived long enough now that I've seen these kids that I work with grow into wonderfully productive adults. They were, if they gave up or if their doctors gave up on them at the time, it would have been a shame because the world would have lost the potential in each person with OCD that's there. That doesn't mean it's easy to climb out of the pit. There are too many things about it in which the principles of learning work against you. The fact that doing the rituals is so rewarding. It gives me relief and freedom from fear for a little while anyway, reliably. And the things that my therapists do, or the idea of exposure, feels like they're going to throw me in the fire. Well, we're not. That's the first thing, is that we're going to try to find a way when you feel ready to take a first step to introduce you to a challenge that'll take a little guts and might be a bit uncomfortable for you. But I'll be here for you. Everybody's rooting for you, like Rocky, give it to Rocky, come on now. All right. So it can be an exciting endeavor of human experience to prevail against such a formidable foe. I've had that experience with so many people. I've had my disappointments too. I want to say that. Um, but so many people that I'm optimistic. I do believe in what we do. I do believe in the human spirit. I believe that people who consult doctors who come in line here are survivors. You haven't succumbed. You're not pulling the covers over your head and giving up. And you haven't found the right path yet, but you've learned things that you can put together in your toolkit because this is a very human enterprise. How many human beings have not had to overcome their shortcomings, their fears, their discomforts in order to live a fully productive life? So this is an exaggerated, kind of distorted form, OCD, but the human spirit is amazing. Every time I see a movie what's better than a movie where, a bad news team prevails and wins the state championship, or somebody overcomes terrible odds. It's what we love about being human, that there's always a possibility of overcoming even what seem to be uh, irresistible odds against us. So that's what I think I would say to people, is that don't give up. You're already a survivor because you're even here listening to us. Because you're a survivor, that means you prevailed against some of the discomforts that have led other people to give up, to think it doesn't work for me. Well, remember, CBT anyway is principle. It's like saying aerodynamics don't work for my airplane, or hydrodynamics don't apply to my boat, and that's why I can build a block and expect it to go fast in the water with a flat front. No, we have to obey the rules, and that's what CBT does. But it's hard to apply them because there's so many different varieties of problems to apply them to, and that's where the creativity comes from the therapist, but also from you. I learned many of the techniques by listening to what worked with people who said, you know what, that really helped. That of all things helped. Remember, I mentioned the two articles that I read. One
Yeah.
that was written by an entirely different author, and interviewed this woman. And when I learned that what the girl thought made the difference was communicating with it directly as a valid source of information, as the person I was working with. I wasn't working with the parents. I'll tell them how to help, but we're working together. That, and the boy who said it was really the human connection. It was talking about music and learning about that you had a life. It doesn't might not always work with everybody. Some people will, well, I don't want to talk about that. Let's get down to work and do the but working with each person, and every therapist isn't everybody's cup of tea. Each therapist is not everyone's cup of tea. So sometimes we have to shop around, and decide and learn from our errors. And we have to work as patients to shape our therapist. When we have someone that's good enough, no one's perfect, but good enough, we have to shape them by giving them honest feedback, right? You don't have to take care of your therapist. You don't have to tell them, that everything's good. I have no problem at all. We need honesty because that's accurate information. It helps us know what we need to do next, whether we need to modify what we're doing, throw it out, and try something different. So you are an active part of this process. And the more active you are in thinking on your own, in reading on your own, learning about OCD, talking to people, listening to other people's problems and learning, yes, you're not alone, but you have a unique variety of OCD because you put it together out of that creative, free-ranging mind. That can work for you because that'll make you inventive and fun and good company and industrious and everything, all the things bosses want and friends want. And on the other side, you're a strong feeling person. You're not a cold fish. So people can connect with the feelings you have if they are willing to do that. And once they understand it, others understand that OCD is like two-thirds invisible. What you think and what you feel aren't seen to other people. And it's hard to open up sometimes. It's you want to protect and pretend as if, hey, I've got it all together. Just leave me alone. Let me do my thing. But really acknowledging that my thing, which is compulsions, a life of compulsions, is only keeping me stuck in this pit, in this forest. And I need to begin to open up my own mind. As I've suggested, therapists, we need to open up our mind and there's no one thing because everybody's different, but to
Right.
find a pathway that allows you as a survivor to claw your way and sometimes leap your way to a better life.
Well, that truly is inspirational. And I want everybody just to remember that you can do this, right? Everybody who's on here, I know, and they hear me say it all the time. You can do it. You have the power to do it. It's been done. And you build upon your successes, right? So if you're able to do it for one, you tell yourself, I can actually do this. That means something for the next time. So um, thank you so much for your time today. Again, you're one of my heroes. I know that everybody on here appreciates the fact that you took time out of your Sunday to do this. And I will always be indebted to you. All of the work, all of the work that I do in the OCD world has some. This is like the 6 degrees of Kevin Bacon. It all kind of relates back to Charlie Mansueto. So thank you, Charlie, for everything you've done. You were truly a gentleman and a scholar, and I've really enjoyed it. So with that, I'll Charlie, I'll give you like 2 seconds to say goodbye to everybody, and then we will go ahead and close up shop for the day.
Shannon, thank you for the work you do and thank you for inviting me. This is, as you might see, I get turned on by just being able to talk about these things. I get excited. It's important. And learning is behind so much of what makes us human and what makes us achieve things in life that we might not. So I've been very lucky to have experiences that shape me in ways that are very desirable. My wife just said she knows I'm not good with time. She went like
Yeah,
that in case I have
yeah.
a she said, like, shut up. But I
No,
want
I saw that happening. I didn't even know who it was. I go, somebody's
to,
telling him
uh,
it's
so,
time to go.
so it should tell you I have things to work on too. Time is
Yeah.
one important one, but thank you for the opportunity. I wish
Yeah.
you all the best of luck and keep plugging away. Yes.
Appreciate it, Charlie. All right, everybody. We'll call that a wrap. Thank you, and we'll see you the next time. All right. Bye-bye.
Fantastic. Bye-bye.
Bye.